Go ahead. Let me share it 1 second.
Okay. Okay, ready?
Wait, I don't know. Can you see it?
Yeah, I can. I'm also looking at my iPad, so I gotta go back and forth.
Okay, go ahead.
Okay. This is Pregnancy and Breastfeeding by Keely and Jessica. The learning objectives are to identify main concerns in drug administration during pregnancy, understand pregnancy trimesters and dental treatment timing, recognize safe and unsafe drugs in pregnancy and lactation. The general dental guidelines: avoid any elective treatment during first and third trimesters. Only use necessary drugs after risk-benefit evaluation. Coordinate the obstetric health professional and maintain detailed documentation. The management of pregnant dental patients. Once again, elective care is only in the second trimester. Avoid unnecessary radiographs. Prevent periodontal disease associated with low birth weight, and modify positioning. Typically, you elevate the right hip in late pregnancy, and you can't lean them back. The main concerns is teratogenic effects, abnormal fetal development, near-term fetal reactions, respiratory depression, and jaundice are some examples. Emerging concern is long-term developmental effects. And then there's a picture with a baby with alcohol fetal syndrome, which is part of a teratogenic effect, and then certain medications that are typically seen to cause it. And then the history of teratogenicity. 1941, German measles was the main cause of birth defects. Then 1961, Belodome tragedy to phocomelia. Recognition of drugs and environment cause congenital abnormalities. Then in your pregnancy trimesters overviews, the first trimester you can have organogenesis. Is the most critical phase of the pregnancy, and you need to avoid any drugs. The second trimester is the safest for dental treatment and prophylaxis. The third, you need to avoid prolonged treatment and risk of premature labor. And then the little image at the bottom shows little examples of what you can do during each trimester. So the first trimester is good for plaque control, oral hygiene instruction, basic scaling and polishing. Avoid elective treatment, urgent care only. Second trimester, plaque control, oral hygiene instruction, scaling, polishing, and it's safe for routine dental care. The third trimester is still plaque control, oral hygiene instruction, scaling and polishing. And then after middle of third trimester, elective care should be avoided. And then teratogenicity challenges, differences between species and timing, varying drug effects and abnormalities, delayed manifestation of effects, difficult to prove teratogenicity in humans. And then the image is just like the mother's exposure and prenatal exposure to everything that could potentially cause teratogenicity. Next slide. Known teratogenic drugs: thalidomide, isotretinoin, warfarin, lithium, and valproic acid. Tetracycline is tooth discoloration and bone defects. Alcohol leads to alcohol fetal syndrome, and then there's a picture of a baby with tetracycline tooth discoloration. FDA pregnancy and lactation labeling changes. The old system categories are A through X, now obsolete. The new since 2015, narratives labeling, and it includes pregnancy, lactation, and reproductive potential. FDA sections explained. 8.1 is pregnancy, dosing, and fetal risk summary. 8.2 is lactation, drug effects on nursing child. 8.3 is reproductive potential, fertility, and contraceptive guidelines. And then we have breastfeeding overview. Almost all drugs pass into breast milk. Risks depend on plasma concentration, lipid solubility, and protein binding. Use LactMed for the database for safety info on the drugs. Managing drug use during lactation. Weigh maternal benefit versus infant risk. Avoid it if the risk is outweighing the benefit for the mother. If contraindicated, stop or pump and dump. Time nursing sessions to reduce infant exposure. Dental drugs during pregnancy. Principle used only if benefits outweigh the risk. Consult healthcare provider. And then table 22.2 in the book summarizes the drug safety. And then the image just shows that the drugs not only affect the mother, but it affects the fetus, and it could potentially also affect the germ cells for the next generation as well. And then we have local anesthetics. Lidocaine is the safest and most preferred. Avoid bupivacaine, heterogenic in animals. Use low doses. Avoid high vasoconstrictor doses. Vasoconstrictors, you have epinephrine. It's safe in small doses. Large doses can lead to fetal hypoxia from vasoconstriction. And then limit cardiac dose. Prefer pain anesthetic for short procedures.
All right, and then now with my slides, I'll be talking on my first one, opioid drugs. Due to their risk to the baby, they should only be used extreme cases and in small doses. High doses, neonatal respiratory depression, and then prolonged use infant withdrawal. Codeine, is that how you say it? Linked to cleft lip. Yeah, linked to cleft lip palate used cautiously. Small doses during lactation are generally safe. Anti-infective agents, only specified indication should be used to prescribe anti-infectives. Avoid use them needlessly as a form of prevention. Find a balance between the baby safety and maternal health. Systemic therapy must be supported by the infection. When possible, local treatments are preferred. Penicillins and I don't even know how to say that. Cephalosporins. The safest antibiotic used in dentistry during pregnant are penicillins and cephalosporins. Amoxicillin, ampicillins, and then penicillins V5 are preferred. No toxic effect appears in breast milk and may cause mild diarrhea or allergy. Macrolides are safe for penicillins allergies patients, but caution is advised with certain forms. Erythromycin, except acetylate form, and then they're safe. Acetylate form, reversible liver toxicity. Clarithromycin, I don't know how to say these words, they're very hard. Avoid in pregnancy. Azithromycin, caution advised. Tetracycline are contraindicated because they cause tooth discoloration and bone growth inhibition in the fetus. Cross-Plexin stains decisus teeth, inhibit bone growth, cause maternal hepatotoxicity at high doses. Avoid in both pregnancy and breastfeeding. Lord. Clindamycin and metronidazole. They're safe are alternative for anaerobic infections, and then metronidazole. Is that how you say it? Metronidazole requires cautions. They're low fetal risk, good for penicillin allergic patients. Avoid in the first trimesters, and then nursing mother exposed and discard milk during the metronidazole use. Antifungal agents, they're typically antifungals like nistane and clotrimazole are preferred because they are poorly absorbed systemically. They're safe. Nystatin is safest, not systemically absorbed. Low risk, limited absorption. Right, and then I have antiviral agents. There are a few antivirals have sufficient safety data for pregnancy. Avoid unless absolutely necessary. There are oxyclovir, limited experience. Avoid if possible. Penciclovir, typically low risk in animals. Breastfeeding antivirals often concentrated in milk. Avoid. and then that should be avoided. All right, anti-anxiety agent, benzodiazepine,
Benzodiazepines.
Benzodiazepine can cause congenital abnormalities and neonatal depends. So they should not be used for dental anxiety during pregnancy. Linked to cleft lip palate. Avoid internally in dental settings. Can cause floppy infant syndrome. Long-term use, sedation in nursing infant. And then I have nitrous oxide in dentistry. Exposure poses
reproductive
reproductive risk to both pregnant patients and dental workers. Restricted uses and proper air are necessary. Chronic exposure increased miscarriage risk. Short-term use with oxygen equal acceptable cautions. Female staff should avoid long-term exposure. Amount of milk negligible.
Negligible.
Alcohol in pregnancy. Since there is no known safe level of alcohol must be completely avoided as recognized detergent linked to the FAS growth retardations, abnormalities in the central nerve system, and specific facial features are a sign of FAS, which has long-lasting dose-related effect. Dental experts should advise patients to stay away completely from alcohol during pregnancy due to these concerns. Breastfeeding concentration. During lactation, nearly all drug enter breast milk in varying concentration. Dosing and timing must be managed carefully. Use lowest dose shortly duration. Avoid unnecessary medication. Refer to the lactum database for guidance and schedule nursing to minimize infant exposure. Drugs concentrated during breastfeeding. Certain drugs are unsafe for nursing mothers and requires discounting or temporary halting breastfeeding. Anti-nephroplastics, lithium and metronidazole. Short-term exposure, express and discard milk when needed. Resume nursing after drug elimination. Coordination and communication. Pregnant and nursing patient receive safe care when the dentist, hygienist, and medical professional work together. It is important to consult the doctor before prescribing. Record every communication. Teach patient the value of oral hygiene and place a focus on both periodontal care and appropriate nutrition. Key takeaways: dental care during pregnancy and lactation can be safely managed with informed decision making. Caution drug use and interprofessional communication. Second trimester safest for care. Use lidocaine lidocaine, acetaminophen, and penicillin. When indicated, avoid NSAID as tetracycline, benzodiazepines. Educate mother on drug safety and oral health. And this is our reference page. Sorry for all these terms that I couldn't say. All right.